Good morning, everyone. My name is Annette Johns, and I'm the Associate Director of Policy and Practice with the Newfoundland and Labrador Association of Social Workers. I have the honor of being the moderator for today's education event titled Medication, Mobility, MAiD, and Making Meaning, Everyday Ethics in Social Work with Older Adults. The NLASW aims to offer an annual education event for social workers who work with seniors, and we're so pleased that the focus of our session today is on gerontology and ethics. This webinar is a collaboration between the Newfoundland and Labrador Association of Social Workers and the Canadian Association of Social Workers. I'm pleased to note that we have over 200 social workers from across Newfoundland and Labrador tuning in this morning. Before I introduce our presenter, I just want to go through a few housekeeping details. The webinar presentation will be approximately 60 minutes, followed by a 30-minute Q&A period that I will moderate. Please note that the recording of this webinar, the PowerPoint, and NLASW guideline documents, which include our MAiD document and what social workers need to know, and our ethical decision-making resource guide, are available on the NLASW website. And we'll also have the PowerPoint and the recording of this webinar under our continuing education button in the coming weeks. During the presentation, I encourage you to type in your questions at any time, and I'll begin asking them towards the end of the presentation or throughout the presentation as deemed appropriate. Only the presenter and I will see the questions and who is asking the questions. A certificate of attendance will be available at the end of the presentation. You just need to simply click on the yellow rightmost icon at the bottom of this presentation window when the presentation is wrapping up. So I now want to introduce our speaker for this morning. Dr. Gail Weidman is a registered social worker and has worked for 15 years as a social work practitioner. She began her involvement in the School of Social Work at Memorial University as a sessional and per-course instructor in 2001 and became full-time faculty member in 2009. Her academic interests span the fields of gerontology and community development. Throughout her career, she has been involved primarily in community-based programs and services aimed at maintaining and enhancing independence and quality of life for older persons. In 2016, Gail received funding to investigate mechanisms of support for informal providers of palliative and end-of-life care in rural communities. Gail is also a proud military mom and has been working to facilitate collaborative partnerships between the Canadian Armed Forces service providers, researchers, community leaders, and families toward the creation of military and veteran-friendly communities. So without further ado, I'll now pass it over to Gail to begin the presentation.
Good morning, and thank you for giving me the opportunity to talk to you today about what I've learned as a practitioner and researcher about ethics in aging. The title of this presentation is my effort to represent the breadth and complexity of potential ethical issues related to social work with older adults. Respect, self-determination, autonomy, protection from harm, and social justice are ethical principles that will be highlighted in our conversation today. But I want to begin by contextualizing this topic using some case studies for you to think about. Irene is an 88-year-old widow, moved into her daughter's house because of increasing frailty. The daughter, who is also caring on her own for her 11-year-old son, who is disabled, is only marginally able to cope with the stress. Irene attended a daycare center for seniors that you are in charge of. At that time, you noticed bruises on her legs and arms. This is the third time in a month that this has occurred, and you suspect elder abuse. You're also concerned about the regulation of her medication. Irene cries when you question her about her situation at home, but says over and again that she loves her daughter and grandson, couldn't bear to be away from them, and that she wants to spend these last years of her life with her family. The nearest nursing home is 2 hours away. So that's Irene. Now I want you to think about Kurt and Rosa. Kurt and Rosa are elderly and have severe disabilities and mobility restrictions that, with recent changes, require 24-hour care. They're adamant about remaining in their own home but want more hours of home care. Community supports are providing as much support as they are eligible for and that agencies' resources allow, but the couple still remain at risk. There's no extended family. Kurt is confined to a wheelchair and frequently smells of urine and alcohol, and both Kurt and Rosa appear dirty and disheveled at times. It's increasingly difficult to find home care workers willing to work with this couple. The neighbors are distressed and have threatened to go to the press. So that's the situation for Kurt and Rosa. Now, Winnie was diagnosed with Alzheimer's disease several years ago. At that time, she sat down with her family and discussed advance directives with them, stating that she did not want any invasive procedures undertaken in the event that she became acutely ill but could not speak on her behalf. For the last 2 years, she's been living on the locked unit of the nursing home. She's mobile and verbal and appears relatively happy and participates in day-to-day activities of the center, but no longer requires any members of her family. On a routine check to a physician, she's found to have an ailment that requires surgery. Without surgery, she will die relatively quickly, but with surgery, she could live for several more years. Her daughter feels that her mother, Winnie, should be allowed to die, but her son disagrees, saying that his mother has changed and would now want to live. The physician has asked you to meet with the family. Now, John, you're working on the admission of John to your nursing home. You're informed by the community social worker that she's been working with John and his family for a long time on issues related to his alcohol abuse. He's made significant progress with both his addictions and his family relationships. He's radically reduced but not eliminated drinking alcohol. Your nursing home has a happy hour every afternoon where residents are served one beer or one other alcoholic beverage. His family is worried that he will not be able to cope with the presence of alcohol in the home, and they want him to be banned from happy hour. So I want you to just think about Kurt and Rosa, Irene, Winnie, and John in the context of those principles that we talked about: respect, self-determination, autonomy, protection from harm, and social justice. So for the learning objectives for this webinar, I want you to consider the impact of health and mobility restrictions in a youth-oriented culture, what we think about or what we consider to be successful aging, about the importance of social, familial, and community relationships on physical well-being in old age, about the tensions that arise when social work values collide, like self-determination and autonomy versus protection from harm, and the role of the social worker in caring conversations about dying and death. So as an academic, the best I can provide, I think, for you is what I call the view from 30,000 feet. But I think that thinking about these higher-level ethical principles will guide us, but they can't be considered in isolation of organizational and legal policies that you experience on the ground, including more recent legislation related to medical assistance in dying and the Adult Protection Act. So as an overview for today's presentation, we're going to talk a little bit about what aging in Newfoundland and Labrador looks like, about who we consider to be a senior, about everyday ageism, because I think that this plays an integral role in our ethical decision-making, and finally, a few ideas about how we can respond to ageism. So the demographic picture of aging in Newfoundland and Labrador. So this is not something that you haven't seen before, most likely. We know that in 1951, the proportion of people 65 plus in Newfoundland and Labrador equaled about 6.5%. Population aging around the world is a result of longer life expectancies, lower fertility rates, and the impact of the baby boomers, who are persons born between 1947 and 1966. So here in 1951, we see a typical pyramid shape to the population. In this chart, depicting stats from the 2006 census, we see clearly the bulge created by the baby boomers. At this point in time, persons 65 plus in Newfoundland and Labrador accounted for 13.4% of the population, which was approximately the same in the rest of Canada. But Newfoundland and Labrador has gone from having the highest birth rate in the country to the lowest, and add to this the impact of the economic challenges of the resource industries and the resulting outmigration, which peaked in 1998 at 12,000 and is thought now to be about 3,000 per year. So Newfoundland and Labrador's aging about 4 times faster than the rest of the country. So that by 2026, about 1 in 4 people in our province will be over the age of 65. So this will be the highest proportion of older persons in Canada. So I think these are important projections for us to take into account when we think about work with older adults. It will have significant impact on our social and health care. So here's a chart that just sort of shows you the proportion of older adults in Newfoundland and Labrador as compared to the rest of Canada. So you see the light green there is Newfoundland in 2006, and that increases progressively until the statistics that we just talked about for 2026. So here you can see where we are in relation to Canada, the purple, and also to Saskatchewan and Alberta. Okay. So the population over 65 in rural Newfoundland and Labrador is also a significant feature of our demographics. So in our province, we know that over 50% of people over the age of 65 live in rural Newfoundland, and by rural we mean less than 30% of the community commute to a larger center. And you can see this compared to Ontario and BC. But how are we defining senior? At what point does one become an older adult? So we know that these are pictures that depict what we would probably call successful aging. We also know that many older adults experience discontext in aging. We know that some seniors are very engaged in their lives and communities and families. But for others, loneliness and isolation are abiding. We have some famous Newfoundland agers. This fellow probably needs no introduction, but you might not be familiar with Cecilia Smith of Hawke's Bay, who at 88 shot this bear who had invaded her cabin. So the point is, this is a picture of Mick Jagger at 65 and his father at the time, who was 85. The point is, there isn't one face of aging. When you've met one senior, you've met one senior. There can't possibly be a one-size-fits-all set of programs, services, and resources that will meet each senior's needs. So first, we know that many social and biological factors will have an impact on aging, but by using 65 as a marker of old age, which we often do, we have to realize that we're dealing with an age span of more than 30 years. So we need to revisit our assumptions about aging and old age that are reflected in our policies and practices. So as an example, the age of 65 was identified as a marker of old age by this fellow, Adolphe Quetelet, in 1836. And mandatory retirement was based on this marker in Canada until almost 200 years later in 2012. So let's consider some myths about aging. What is the most prevalent mental health disorder among older persons living in the community? You likely know that it's depression. The prevalence of mental disorders among older persons living in the community ranges from about 15 to 25%, with depression and anxiety most common. Yet less than 25% of older adults who need mental health services receive treatment. A major barrier to treatment is a shortage of geriatric mental health professionals, but other barriers include ageism on the part of healthcare providers, frustration and anxiety with technology like answering machines, and health information that's presented at inappropriate reading levels or in inappropriate formats. So what proportion of persons 65 plus do you think require assistance with activities of daily living? Well, it might surprise you that only 23% of people over the age of 65 require assistance. What is the proportion of persons 65 plus who are online? And these are Canadian statistics. It's actually 59%. Now, these statistics will likely play out differently in places in rural Newfoundland and Labrador, and I think that we have to be really mindful of the way in which we provide information to older adults depending on the context. Computer access will be a really good way to extend the reach of our information services, but not for everyone. So I think we have to continually think about the appropriateness of the format in which we're presenting information. I'm always interested to ask younger people this question. For example, my undergraduate students who are straight out of high school, their answers are always surprising to me, and I think revealing of a disconnect between younger and older generations. So only 5% of people over the age of 65 live in nursing homes, and the statistic is common to Newfoundland as well as in the rest of Canada. Between 5 and 7%. But my younger people that I talk to about this or ask this question always think that it's much, much higher, as high as 50 or 70%. And I think that speaks to this disconnect between younger and older generations. And this is a separation that is fairly unique to modern-day society and has played a real role in terms of ageism and the way we think about older adulthood. Now, that statistics, of course, is higher for people 80 plus, but it's still only around 15 to 20%. So I think we really, that's an important reflection of how we view old age and work with older adults. This was the amount of care estimated to have been provided by unpaid caregivers in 2009. $23 billion worth of care. So informal care, including personal care, household tasks, and help with paperwork, seemingly minor tasks, but my research has indicated that the inability to complete these tasks can trigger self-inflicted notions of dependence and ultimately the consequence of premature institutionalization. So the availability of caregivers and support for caregivers plays a critical role in terms of older adults' ability to age in place. This was the amount of informal care provided by female informal caregivers in 2012. 55%. So it's important to realize that men provide almost as much care to family members as women do, which has implications for our delivery of caregiver support. The Netherlands, France, and Denmark spend 32%, 43%, and 73% respectively on their long-term care budget. Canada spends this percentage on home care. The Nordic countries in particular have always emphasized aging in place, and I think this philosophy is reflected in their investment in home care. This is a general statistic for Canada. In this 2006 study, this is a percentage of women 50 plus who reported feeling comfortable discussing sex with their physician. Only 25%. Stereotypes about sexuality in later life have devastating impacts on intimacy and help-seeking regarding healthy sexual practices by older adults. And finally, ageism. So what is the proportion of Canadians 65 plus who reported in 2012 that they've been discriminated against because of their age? So I don't think it will surprise you to hear that 63% of Canadians 65 plus have been discriminated against. So we know that the proportion of seniors in our province is growing rapidly, that most seniors are relatively active and independent, and that most seniors live in their homes and communities. We know that much care is provided to seniors by unpaid caregivers, that many older people continue to engage in sexual activity but don't feel comfortable discussing sex with their physician, and that most seniors have experienced discrimination because of their age, ageism. In fact, one study reported that so many Canadians look down on seniors that they described ageism as the most tolerated form of social discrimination in Canada. The question is, will our future selves be impacted in the same way by these stereotypes? So ageism is reflected in culture in an important way. So one of the things we talk about is gerontophobia, this fear and vulnerability toward death, and by extension toward aging and older people. Recently, a book has come out by Timothy Caulfield that you might have seen, where he describes the culture of celebrity influence on our ideas about age and aging. So his book is called Is Gwyneth Paltrow Wrong About Everything? And basically, he examines anti-aging messages that are perpetuated in popular media. And his conclusion is that the message is uniform, oppressively consistent, and crystal clear. Don't age. More concerningly, and more divisively, is the perpetuation of the myth that population aging will overburden society's capacity to care, when in fact we know that healthcare costs are driven by increased use of pharmaceuticals, specialists, and technology, and not simply by demographics. So what is ageism? Robert Butler first studied ageism in 1969, and he sort of unpacked the idea of ageism in the following way: as prejudicial attitudes towards older persons, old age, and the aging process; as discriminatory practices against older people by individuals; and institutional policies that are based on and perpetuate stereotypes about older people. He went on to make important distinctions between personal and institutional ageism, and at both those levels, ageism that was intentional and unintentional. In a later work, ageism was noted to be either other or self-directed. So at the age of 62, when I wake up in the morning with aches and pains that I put down to aging, I don't consider that a few weeks of physio or medication might help alleviate this condition. So this is ageism that I direct towards myself. But importantly, research has demonstrated that ageism tends to be higher among health professionals than in the general population. And this is said to be a result of the emphasis on pathology in education. So we're, as social workers and other healthcare professionals, trained to work with people who are vulnerable in later life. In healthcare in particular, there's an emphasis on the cure, making conversations about successful dying unlikely to be within our scope of training. In fact, we work with those most compromised by health and mobility restrictions, so we have a biased experience of aging, and these become the face of aging for us. But as a result, it was found that healthcare providers tend to view elders as resistant, rigid, demanding, and uninteresting. It was reported that 30 to 50% of U.S. physicians limit the number of older adults into their practice. Here in Canada, physicians report that they're not remunerated sufficiently to account for the complex needs of frail older adults. Research has shown that older adults are often provided with narrow assessments, with medical solutions for non-medical needs, for example, pharmacological interventions for needs related to loneliness and isolation that might be addressed with social service, and low expectations re goal formulation, disabling versus enabling, a lack of emphasis on rehabilitation, and psychological disorders that are misdiagnosed as physical ailments, for example, depression misdiagnosed as dementia. It's also important to note that often physical problems are dismissed as part of normal aging, for example, incontinence, arthritis. And how often have we witnessed communication oriented to a third party, for example, the adult child instead of to an older adult? But what is personal ageism? Personal ageism is defined, as I noted, as ideas, attitudes, beliefs, and practices on the part of individuals that are biased against persons or groups based on their older age. As I said, it can be intentional and unintentional. I think this is important to think about. So how many of us have heard or told ageist jokes that seem harmless, but at the end of the day, they perpetuate stereotypes and self-directed ageism? So this is a cartoon of two dinosaurs watching the ark float away, saying to each other, "Oh crap, was that today?" Sort of thinking about describing this as a first senior moment. The idea that with aging comes memory loss. So, and we know that that's partly true, that there's, and this is the thing about stereotypes, they're shortcuts to understanding behavior and experiences. There's kernels of truth there, but it's when they become generalized, inappropriate to groups of people that they become problematic. Of course, the worst examples of personal, intentional ageism are physical or other forms of abuse toward older adults. We know that only about 5% of elder abuse is reported, and that of those, 80 to 90% of elder abusers are family members or someone on whom the older person depends on for care or protection. The most frequently reported elder abuse is financial abuse. So abuse defined as any act or failure to act within a relationship where there is an expectation of trust that jeopardizes the health or well-being of an older person, emotional, financial, physical, or sexual. So while types of elder abuse such as sexual abuse and embezzlement are obviously violations, it's important to note that elder abuse can be inadvertent or unintentional. In fact, 13.2% of reported cases of elder abuse are a result of unintentional neglect of an older person, such as a failure to provide food or health-related services. But these may be the result of a lack of knowledge, inadequate skills or training, or just simply understanding on the part of the caregiver of the necessity of prescribed or essential skills needed to provide care for the older person. Another example of unintentional ageism, I'm sure you've talked about, is elder speak. An example of unintentional personal ageism, elder speak is the patronizing language and changes in speech pattern on the part of younger adults toward older persons. In a study by Becca Levy, a professor at the Yale School of Public Health, it was found that older adults who were exposed to negative stereotypes commonly associated with aging and enforced by elder speak, condescending phrases and attitudes, these people performed significantly worse when tested for memory and balance. And I want to just interject here and say that I know it's a cultural pattern in our communities to use endearments such as dear and ducky, and I think these provide comfort to people as well. But I think the point is to be aware of the impact of elder speak and to check in with the people that we're working with to have a sense of whether or not this is something that would be of comfort to them or which they would experience as ageist. In another study, this retired school teacher said, "I often didn't feel strong enough to answer back, but even worse, I felt that this sort of attitude and message was grinding me down. It reduces your self-esteem, and at times I felt it was just easiest to give in to the stereotype that I didn't know what I wanted or needed." We have been studying elder speak, and this is a model that describes the negative impact that occurs when the speakers receive physical cues, for example, of frailty, that the people to whom they were speaking were old, despite signs that the older persons were mentally and socially alert. The older person on the receiving end of this demeaning communication ends up with a reduced sense of self, lower self-esteem, and perceptions of low self-competence, enforcing the existing stereotypes, often self-inflicted. Institutional ageism, policies, rules, or practices that discriminate against individuals or groups because of their older age. And again, these can be intentional or unintentional. Perhaps the most prominent advocate of age-based rationing of health care, an example of intentional institutional ageism, is the writing of Daniel Callahan, who wrote a book called Setting Limits. In this book, Callahan proposed that the government refuse to pay for life-extending medical care for individuals beyond the age of 70 or 80, and only pay for routine care aimed at relieving their pain. We know that some rationing is necessary and important, but our argument is that age alone is a blunt instrument to use. More recently, and this is the work to which this diagram refers, is the work of Ezekiel Emanuel, who has proposed that what he describes as a complete live system, a centralized system of rationing medical care that limits care for older adults in favor of providing it to younger individuals, otherwise known as the younger first principles. So these are responses to that ageist assumption that I pointed out earlier of apocalyptic demography. There are also unintentional or examples of unintentional institutional ageism, and one of the ones that I think is important to talk about is the idea of functional decline. Functional decline is one of the most common and concerning adverse outcome for the older adult because it causes the older adult to lose certain abilities that allow them to maintain their independence. Examples of typical types of functional decline include problems with vision, hearing, balance, memory, and weakness in bones. It's the result of the interaction between effects of aging and the stresses of hospitalization, and not just age or the disease that brought them to the hospital. So you might have examples in among your clients or friends who go into the hospital for a particular condition, acute condition, and they come out with a chronic condition related to the impact of the environment that they experienced in the hospital. And I'm going to tell you about a study that's taken place here in Eastern Health that's looked very specifically at this. Because the older adult may not fully recover from functional decline, they require more frequent hospitalization, leading to a cycle that continues a decline in function, leading to the inability to return home and forcing premature nursing home placement often, or even increase in mortality rates. Functional decline can exhibit in many forms. Delirium, for example, is a sudden change in a person's mental health, which changes how they think and behave. The older adult will exhibit delirium as memory loss, disorientation, language disturbance, sleep disturbance. The older adult then is often prone to frailty, which is the result of multiple physical and social deficits, leading to an inability to compensate for these additional physical or social stressors. And in the frail older adult, a single or mild precipitating factor, such as hospitalization, is enough to trigger an episode of delirium. It could be related to a reduction in sensory input from just being immobilized, from being interrupted in sleep, along with the stress of illness and the interaction of multiple medications. But other examples are pressure ulcers, so treatment of acute illness, which prevents the older adult from their usual mobility patterns. A decrease in mobility leads to more time in bed, which in combination with the older adult's fragile skin leads to skin breakdown. Falls caused by inaccessibility of fluids, reduced muscle strength, and aerobic capacity from immobilization leads to dizziness and falls. Unfamiliar environments, unclear paths to the toilet, impaired ambulation from the illness, equipment barriers such as bed rails and use of drugs that impact bladder function can lead to incontinence. We know that more than 45% of older adults become incontinent within a day of hospitalization, and that incontinence is one of the greatest predictors for the older adult's ability or inability to return home, often leading to premature placement. So these are elements of they're a result of ageist assumptions and practices, but they're unintentional. So the study that I wanted to refer you to is called Age-Friendly Acute Care. I'm not going to talk too much more about it, but I did want you to have access to that website. So hospitalization, the report talks about the fact that hospitalization triggers functional decline for the reasons mentioned earlier, but including lighting, noise, interrupted sleep patterns, leading to diminished recovery and over-reliance on healthcare providers. Sensory deprivation, just not having your glasses or hearing aids or denture. Inactivity. All of these factors, either alone or in combination, cause dependence on others for the older adult. These are practices intentionally put in place by the institution, these are not practices that are intentionally put in place. to harm older adults, but they are the result of ageist and stereotypical beliefs about the capacity of older adults. So I'd encourage you to take a look at that study done with the Newfoundland Labrador Center for Applied Health Research in collaboration with Eastern Health, because it has provided some interesting findings and recommendations around activity, avoiding bed rest, incorporating activity into the daily care plan, including with the involvement of family. Staff should understand the unique needs of the older adult to ensure recognition of functional decline. Avoid high bed rails and carpeting, being sure that patients have access to their hearing aids, glasses, and good lighting. Communication between multidisciplinary team members to ensure shared objectives and relationship building among team and with patient and family. These are all referred to as age-friendly care. And, of course, medication management. Another example of unintentional institutional ageism was suggested to me by my 75-year-old friend who, when she found out that I was working on a presentation about ageism in healthcare, she said, "You have to talk about sex. Nobody's talking to us about it. They think we're not having it." She described a recent conversation that she had had with several of her women friends. They all agreed that their healthcare professionals did not talk about sex with them. From a study of 2012, we know that the rate of sexually transmitted diseases has more than doubled among middle-aged adults and the elderly over the last decade. The reasons for this are unclear. But ageism and stereotypes regarding sexuality in later life result in a loss of intimacy, embarrassment regarding normal sexual urges, segregation of long-term care residents by gender, even in case of long-term relationships, and challenges in the context of dementia care and inadequate sexual health care overall. And I just wanted to interject here as well to say that I know that FENL, the Provincial Health Ethics Network of Newfoundland and Labrador, is putting together a presentation specifically on dementia care and sexuality that will be available to you in February. I'll be sure that Annette has information about that. So this is a study called Sex in the Elderly, STD Risk Often Ignored, from February 2012. So here you see the rates of syphilis and chlamydia in 2000, and the increase over a decade in the rates from, in one study, close to 2,500 cases of syphilis were reported among adults between the ages of 45 and 65 in 2010. This is up from 900 cases in 2000. The number of reported chlamydia cases in the age group almost tripled from around 6,700 in 2000 to 19,000 a decade later. So among the major findings were that close to 3 out of 10 respondents said they had sex at least once a week, including half of those who were single but dating, 36% who were married, 85% of men, and 61% of women said that sex was important to their quality of life. Just 12% of single men who were dating and 32% of single women who were dating reported using condoms. One cause may be the increased popularity of erectile dysfunction drugs that have made sex possible for many more aging men, but not using condoms because the fear of pregnancy is not there. The contribution of any or all of these factors to the rising STD rate in this age group is not clear because very few researchers have studied the issue. One researcher said, if you want to know about sexually transmitted infections in teens and younger adults, there's plenty of studies to look at, but there's almost nothing to tell us why rates are increasing among older adults. So I just have one caveat, and that is when I looked more carefully at this study, I realized that what they were describing as the elderly were adults between the ages of 45 and 65. So I know from other research that these stats hold for older adults as well, but I wanted to point out to you this sort of interesting definition of terms. So because we don't talk about sex, we don't talk about sexual and gender diversity in later life. LGBTQ seniors experience multiple stressors that arise from being part of a sexual minority and being a senior. We know that up to 12.4% of people 60 and over identify as LGBTQ, and that only 1 in 4 LGBTQ people disclose their sexual orientation to healthcare providers. Fear of stigma, discrimination, prejudice, and internalized homophobia cause older adult LGBTQ adults to go back into the closet if long-term care is needed. Consider the life history of gay Canadians in their 80s. They were born in the early 1930s. They would have lived their first 3 decades as a criminal, the next few years deemed legal but mentally ill, and would only have gained the right to marry in their 60s or 70s. If transgender, they have only just received legal protection from discrimination. I want to talk a little bit now about the importance of self-perception, the impact of ageism. The importance of positive self-perception cannot be understated. In a longitudinal study that was conducted of 600 people over 23 years by researchers at Yale University, found that the effect of positive self-perception of aging is greater than the effects of controlling blood pressure and cholesterol with no history of smoking and tendency to exercise. So positive self-perceptions have a significant impact on our health, and yet we certainly don't hear as much about that as we do hear about the impacts of smoking and of diet and of lifestyle. This was also a finding in Levy's study. Here, the blue line is the increased number of negative age stereotypes and its correlation with increased number of cardiovascular events. So the higher degree of negative self-perception, the greater number of cardiovascular events. Another impact of ageism is on activity in older adults. So we know that only 15% of older adults are sufficiently active. We know that older men and women stop being active because society expects them to. Inactive Canadians are aging about twice as fast as nature intended due to heart disease and functional loss brought about by our increasingly inactive lifestyles. And that sedentary lifestyles lead to the same risks as pack-a-day smokers. But how does all of this apply to ethics and aging? How do we overcome everyday ageism and apply principles of respect, self-determination, autonomy, protection from harm, and social justice to the cases presented at the beginning of this discussion? To Irene, who you suspect is being unintentionally abused or neglected and whose medication seems unregulated, but she's willing to sacrifice her relationship with her family to enable you to, she's unwilling to sacrifice her relationship with her family to enable you to investigate. To Kurt and Rosa, who despite disability and mobility restrictions are adamant about staying at home, even though the risks of staying at home are not viable. To Winnie, whose wishes for what she understood as the options for what we would now call medical assistance in dying were made very clear prior to the onset of dementia, but are now the cause of family dissent. And for John, whose enjoyment of life has always focused on his family and their well-being, but whose personal enjoyment includes alcohol, and his autonomy in this regard is now constrained by facility regulations and by the wishes of his family. So what we believe about normal aging does have an impact on professional ethical decision-making on issues such as risk tolerance, self-determination, autonomy, protection from harm, competency, and capacity. Ageism affects the choices people are presented with and the decisions made based on what is believed to be the inevitable deterioration of later life. This is described as the reciprocal nature of ageism, disempowerment created by myths and stereotypes. But even in the context of the conditions of frailty and decline that sometimes accompany later life, having choice and control is a fundamental human need that doesn't diminish. So I want to talk a little bit now about how do we respond. So keeping in mind that this is my view from 30,000 feet as an academic, I want to propose three lenses from which to think about ethical issues in social work with older adults. The first is empowerment-oriented practice. The second, critical gerontology. And finally, knowing oneself ethically. But first, a note about choice and control. We know that the world of frail older adulthood can become very small, and therefore it's critical to remember that, as McKennis-Dietrich points out, it's not the size of the decision, but the ability to make it that is empowering. So I want to first talk about what's described by Cox and Parsons as empowerment-oriented practice. So I think we don't often consider the notion of social justice in relation to older adults and their capacity for social action. So one approach to ethical practice with older adults is to focus on empowerment. Empowerment-oriented practice is the engagement of individuals in actions that challenge or change the personal, interpersonal, or political aspects of their life situations and are oriented to community-dwelling older adults. But it contains four key elements. The first is attitudes, values, and beliefs. The psychological attitude developed through the empowerment process comprises self-efficacy and a sense of self, a belief in self-worth, addressing the impact of ageism, self and other directed. Through the empowerment process, individuals recognize that experiences are not unique but shared, reducing self-blame, increasing the tendency to look for causes other than personal failure in groups, provides a sense of mutual validation. Find these in self-help groups. Through this empowerment process, individuals become able to think critically about the internal and external aspects of the problem. They are able to identify macro-level structures and their impact, as well as explore the ways in which their own values and attitudes have been acquired and how they affect the problem at hand. Being empowered includes learning to think critically, acquiring the skills needed to access information and to take action. Through the empowerment process, individuals are able to develop action strategies and cultivate the resources, knowledge, and skills necessary to influence internal and external structures, along with acting with others for the attainment of common goals and social change. So I think this is a sort of unique structure or framework for empowerment-oriented practice that considers social justice and older adults' capacity to make change in their lives, both at the personal and at the political level as well. So Cox and Parsons go on to talk about, so in addition to this framework, they talk about dimensions of empowerment. Individual work with clients related to lack of resources, interpersonal conflicts, emotional issues, environmental problems, or other concerns raised by the client. So at the individual level, the problem is likely to be viewed by the older person as a personal problem, and this is probably where most of our practice with older adults takes place. There are other options available to us, and she describes small group work with clients designed to provide general knowledge and skills around coping with common transitions associated with aging, retirement, loss, physical decline, forming networks of individuals who have common needs and interests. The focus is on the alleviation of a shared problem. Now, when I worked for the local CNIB as their senior worker many years ago, one of the things we did was a book club for older adults who were experiencing the onset of low vision. So it enabled them to sort of talk together to about their shared experience, but also just to generally learn about ways to use talking books, for example. The tape talking book machines in those days, they're highly technologized now, but 20 years ago we were still using tape machines. It made a huge difference in people's life who were not able to read anymore. And I don't know if that would have happened so successfully without that small group interaction. Interventions on Dimension 3 are focused on change or mediation within the client's immediate environment. So working with clients to engage effectively in activities that will facilitate change. For example, on issues related to access to health care, social services, income support, and transportation. In this dimension, we do consider other kinds of self-help approaches. Work with clients in this dimension, the fourth dimension, is aimed at involvement in the political aspects of their problems. So clients' collective knowledge is combined with knowledge from formal sources that provide the foundation for social action. For example, some of you may know of the Peer Advocate Program of the Seniors Resource Center of Newfoundland and Labrador. So understanding personal problems as political issues is a principle that guides consciousness raising in all four dimensions of intervention. So whether you think of, and here's where we're getting into the view from 30,000 feet and why I think it's important for you to think about those larger principles of respect and autonomy and social justice, even in relation to your one-on-one work with clients. The workers seeking to facilitate empowerment assists older adult clients to understand their difficulties as problems frequently experienced by other older adults, and to see the relationship of their problems to the society as a whole. The worker then serves as a catalyst by raising questions about the relationship between private problems and public issues. Finally, critical gerontology. So a second approach to ethical practice with older adults is to consider the impact of critical gerontology. So this is an emerging way of thinking about the experience of age and aging. In the early 1900s, we thought of aging as primarily biomedical concern. By the 1930s, we were beginning to recognize the impact of a growing proportion of the population being elderly. And then by the 50s, we began to talk about successful aging and the avoidance of disease. But more recently, we've taken a broader psychosocial approach to what we now think of as critical theory or critical gerontology. So we look at the assumptions that underlie our policies and services, including the fact that life choices play a role, but so do social circumstances, access to income, nutritional food, housing, and healthcare. There are many factors beyond individual lifestyle and choice that contribute to successful aging. This is a picture of a couple that had been together for, I think, about 40 years before they were allowed to legally marry. So considering the intersection of issues in addition to age. Critical gerontology then takes us beyond the medical model of aging. It understands aging as politically and socially constructed and considers humanistic and structural factors such as self and other directed ageism, the influence of intentional and unintentional ageism on the experience of aging. But most importantly, it includes what we describe as emancipatory praxis, including from ideals of successful aging. Recognizing physical and personal losses in old age as, for some, essential elements in the life course, and dismantling the idea that disabling conditions are evidence of one's failure to age successfully. So while I applaud the agility of the woman in this picture, I recognize that this is an exceptional, not normally attainable feat. And finally, self-awareness. Addressing ethical issues related to aging requires self-awareness. This is an article by Abramson that I use with my students a lot because it really asks questions that engage you in thinking about the ways in which your own values and assumptions might impact your ethical decision making. So for the next couple of slides, I'm going to just ask you a few questions. I'm going to end the session by asking you some questions that will require you to think about the fundamental ethical values that guide your thinking about social work practice with older adults. And I just want you to think about these as a sort of framework for understanding your own values and assumptions and beliefs about aging and how those might impact your practice. So prejudgments. How has your personal and cultural history shaped your thoughts and actions about aging? Your views about aging and older adults? What is your image of a morally good person? How in your view, should we respond to the needs of older adults in our society? How do we apply the social work values that are the founding of our profession to work with older adults? How do you feel, for example, about assisted suicide? We talk about in ethical theory about principles of beneficence and non-maleficence, so either doing good or doing no harm, and justice. Where do you stand on these principles? How important are they to you? When these roles conflict, which are you likely to choose? Is respecting a client's self-determination or autonomy more important than doing good or not doing harm? What is your level of tolerance for risk-taking in your older clients? Where do you stand in relation to these grand ethical theories, either utilitarian, where actions are right or wrong depending on their outcomes, or deontological, which is more rule-based, that actions in and of themselves are inherently good or bad? Do you believe that you should always protect your clients from harm because that's the inherently good thing to do? Or should you enable risk-taking because autonomy and self-determination is the overriding value? Do you believe that human beings shape their own destinies? Or are you more likely to think that human behavior is the result of factors over which people have no control? What are your beliefs about spirituality? How do these beliefs affect your relationships with persons who have different beliefs? What are your views of individual rights versus the good of the community? Under what circumstances are your sympathies more likely to be with one or the other? How are you likely to resolve a dilemma of this for yourself? And finally, voice. What is your preference for approaching ethical problems? Which will you emphasize? Justice, rights, privacy, and non-interference? Or are you more likely to focus on relationships, intimacy, and self as connected to community interests? So just to summarize, the face of aging is diverse. Ageist stereotypes result in ineffective and potentially unethical attitudes, policies, and practices. Ageism can be self or other-directed, personal or institutional, and intentional or unintentional. Ethical practice with older adults includes an emphasis on choice and control, a critical and reflective approach to ensure that practices and programs with and for older persons emphasize diversity and importance of self-awareness in regard to ethical decision-making. And also, and I think this is important, an acceptance of aging as a deeply human experience. These are our future selves, and for some it will include vulnerability. So I'm just going to conclude with by reading an excerpt from an article, again an older article, 1969, that talks about the importance or the value of social work with older persons and what it can mean to us personally and professionally. So David Sawyer writes, I believe that working with the aged is one of those fields in social work that by setting forth the issue so clearly gives the worker a chance to test, temper, and affirm the core value of our profession. But far deeper than one's sense of values, more soul-pervasive than any professional commitments, is the confrontation with one's own mortality. For working with the aged brings the worker face to face with the decline and end of the individual life. This confrontation with mortality and successful coping with it can be a most precious professional and personal experience. Working with older adults can be a testing and affirmation of certain of the basic values of our profession, especially of the intrinsic value of the human being. It can confront the social worker with our mortality and open us to a deep struggle with this most basic dilemma. The perspective gained in working with the aged, the looking backward upon a life, can broaden one's sensitivity to the full range of human experience. There's a certain purity about working with the aged, especially those who are beyond the production years. One doesn't justify this work on the basis of crime prevention or helping to develop untapped potential productive forces. One justifies it only on the basis that each human being has value, intrinsic value, the meaning and dignity of being human. When one works with younger people and the world is open and one is looking ahead, there can be a terrible striving to make one's client normal within whatever definition the worker has of that concept. But work with the aged is different. There is a look backward. No longer is there a dream of what life may become, but there's a stark look at what was. There is a search for the things that gave life meaning. I believe that working with older people can sensitize a social worker to the treasures, the moments, the paper shreds that give meaning to life. So I've used Sawyer's work often in my classes and in presentations to inspire, to motivate, and to normalize the experience of aging in our society for social work students. Thank you for the opportunity to share it with you. I started this presentation by describing it as the view from 30,000 feet, a perspective that I hope you will consider in your day-to-day work, thinking intentionally about where you reside in relation to these broader ethical principles of respect, self-determination, autonomy, social justice. In the context of a still ageist society, I think this will inform your interpretation and implementation of the policies and laws that also guide your practice with older adults. Thank you.
Gail, thank you so much for this wonderful presentation. So much great material. So we're now going to move on to our question and answer section, and we're going to do our best to get through all the questions. However, we do thank you for your understanding if we're not able to get to them. The first couple questions I'm going to combine because they're related to the statistics on nursing homes that you presented earlier in the presentation. So when you talk about the nursing homes, are you referring only to the level 3 long-term care facilities, or are personal care homes included in that data? And also, what year is that data from?
So that's a Canadian statistic, and personal care homes are not a type of facility that is available all across Canada. So I'm going to say that yes, it refers only to nursing homes. And I'm not sure exactly of the year of that particular statistic, but I know that it has stayed around 5 to 7% over the past decade or so.
Okay, thank you. Another practical question in terms of where participants might find the link to the study about hospitalization leading to functional decline.
So the link is there on the Newfoundland and Labrador Center for Applied Health Research. Look under CRISP, CHRSP, which stands for Contextualized Health Research Synthesis Program. So the idea of that program is that questions are brought to the NLCHR from the healthcare system, and they set up a whole research protocol that then does a systematic review of the literature, contextualizes it back to Newfoundland and Labrador, and then prepares a report. So that is a really excellent report that I think that you'll find interesting. But it's there on a link at the website for the NLCAHR. If you just drop that into Google, it will take you to the Applied Center for Health Research, and you will find it there.
Just a comment around the unintentional decline. I don't know if you had a comment around this. Unintentional decline in healthcare settings, long-term care facilities, is very much a reality, but those settings know that it's happening. Ironically, while unintentional, it is deemed systematic and unfortunately acceptable.
That's a great point, and that's why I really like to use the way Robert Butler has made a distinction between unintentional and intentional. So it's still ageism. It may be unintentional, but it still can be framed as an ageist practice. And I think when we think about it in those terms, we can sort of take a step back from some of the systems and protocols that guide our practices in an unfortunate way.
Thank you. What strategies have you found to be helpful when advocating within systems for enhanced services and programs for seniors, or what should be guiding our work in that area?
So as I said earlier to Annette, this really is the view from 30,000 feet. So as academics, we're cognizant of the fact that we're not working with you there on the ground always. So I framed this in terms of those grander ethical theories because I think those are the things that you can use to guide your conversations with policymakers and program planners. So these are not just operational issues; these are ethical issues that we're talking about and that are reflected in our programs and policies. So, if there was a strategy, or if we could describe this as a strategy, I think it would be to just really use the language of ethical principles in your conversations about the changes that need to be made in your policies and programs and practices.
Excellent. Thank you so much, Gail. Another question from a participant is around capacity. So capacity is a huge piece of the Adult Protection Act. Working with hard of hearing adults, illiterate, or visually impaired seniors make tests such as the standardized mini-mental state examination unusable. Just wondering if there are better tools to use to quickly assess capacity.
Another great question, and so the short answer is not that I'm aware of, although I'm very aware of the limitations of the mini-mental. But I also, just to comment on the Adult Protection Act, one of the things that I think has been really valuable about the process of working and developing the Act is the attention that's been paid to issues related to competency and capacity. And yes, I recognize what a challenge it is to enact the Act under conditions of other losses associated with later life. So I'm not sure if you've had an opportunity to really have presentations on the development of the Adult Protection Act, or I know that Annette also has done some work in relation to its impact, but I think that we really need to press for, the language is there around competency and capacity, and I think we really need to press for education and tools that can help us fine-tune our practices in relation to the Act.
Thank you, Gail. And if I could just provide a comment around that as well. Many of you online would know that the NLASW produced a discussion paper in 2012 called Social Work and Decision-Specific Capacity Assessments, and that resource is available on our website because we do highlight some tools in that particular document, the mini-mental health exam being one, the capacity assessment tool, the MacArthur competence assessment tool, and also William Malloy's tool as well. And the reference for that will be in the document because they talk about, decision-specific and capacity assessments in domains around health, property, driving, sexuality, intimacy, among others. and in consultation with colleagues who helped inform the development of this paper, noting that the clinical interview is the key tool for assessing capacity and would need to be tailored for each individual situation. And in the document, we do provide a sample interview that was used to resolve a particular issue regarding capacity within a site. So I encourage you to check out that document as well. And if you have any questions around that, please feel free to give us a call. So moving on to some other questions. We still have some time left, which is great. What can social workers do to ensure that we and our organizations are providing welcoming environments for LGBTQ seniors?
Well, I think that I know that there's work being done on this in some residences in Newfoundland and Labrador. I think when I imagine what it would be like to be in an LGBTQ welcoming environment, I think about the notion that we talk about in social work of privilege. So, we as heterosexuals, or we have a sense of privilege where we sometimes don't always that's kind of invisible to us. So I think it's important to think about what are the things that I can enjoy. So I can walk down the street holding hands with my husband, and no one has a second thought about that. So what are the things that you feel that your non-LGBTQ residents can appreciate that isn't there for the LGBTQ residents that you have? I think inclusive questioning has been raised as an important way of starting right off at the assessment. How can you at the beginning stage of your assessment use inclusive questioning so that LGBTQ people see themselves, see this as a safe place for them? Now, the bigger challenge is how do nursing homes as communities address prejudice and discrimination, because we're the cohort that are now residing in our nursing homes are likely to have less enlightened views and stereotypes about sexual and gender diversity. So I think that in addition to those the day-to-day practices that can be done to make it an LGBTQ-friendly space are one thing, but I think a general education and awareness needs to take place, because this is a community, and the community and that are people's homes. So, I think it's a multi-level approach that needs to be undertaken.
Thank you very much. Next, we have a question, more of a opinion-type question, I guess. Gail, do you think government could be doing more to get more personal care homes in rural communities? The member noted that many people are reluctant to move into personal care homes because they do not want to travel 2 to 3 hours from their hometown.
Here's where I wish I could see you, although I did spill coffee all over my T-shirt this morning, so I was pretty thankful that this is a webinar. But I really wish I could talk a little bit about your awareness of the current provincial home care review that's taking place, which is very broad in scope and which will include a review of our, for example, personal care homes, because as a result of a review done by John Abbott with Deloitte, there was a very detailed I think we have a very detailed understanding of the things that need to change within the big picture of our long-term care. And by long-term care, I mean that the whole scope of long-term care, the spectrum, or rather, of long-term care. So the short answer is yes. I think that we do need to be doing more. And on the positive side, being part of that committee, I'm aware of the really intensive work that's being done to address the issues that we have heard about that are problematic, including the one that you've just raised here. Now, that report by Deloitte is available somewhere. It was a provincial home support review, and I think if you just drop that into Google, you should be able to find it. So Provincial Home Support Review, Newfoundland and Labrador by Deloitte. I think you should be able to find it, but it outlines a very detailed plan for addressing these issues. So I think you will be that's a very positive step that we're taking.
Thank you. We still have some more time for questions, so we'll keep going. Why do you think it is that we have such a hard time recruiting young people into the field of geriatric social work, so new graduates who are coming out of social work programs?
Well, I think this relates back to my observation regarding ageism in general, but in particular, I think social workers, young social workers or young people are of the view that most older people live in nursing homes, and so they believe that their practice as social workers with geriatric population will be in a nursing home, and if that's not their interest, then I think they're not. They just don't see themselves there. So I do my best. We have one gerontology social work course that is available for people to take as an elective. But I think that for the most part, people just don't recognize the diversity of practice that they can be involved in. That the empowerment-oriented practice that I talked about in communities with groups. Very exciting things happening with groups here in Newfoundland and Labrador who are very engaged politically and older adults. So I think that's young social workers, young people. Just again, it's a very ageist stereotype. They just don't see the diversity of the lives that older adults live.
Thank you. And I think we'll take probably two more questions. When the ethical principles of self-determination, best interest of the client conflict with the social worker's perception of the best course of action for a client, what are some of the pieces that we need to be considering?
So I think my answer to that question will be to go back to think about the ethical framework, the ethical decision-making frameworks that you've learned about. And I think probably, no matter what framework that you use, a place to start is to examine your own values and assumptions and to consult with your supervisors and your colleagues and really being aware of how your own values and assumptions are guiding your decision making, so that you know that what you are working toward really is in the best interest of your clients and the people that you're working with.
Perfect. And last question, what is the number one piece of advice you would give to someone entering geriatric social work?
I think, I think it's advice we give to social workers entering any area of practice, and that is to really consider, start with where the client is, consider the diverse interests and needs and values, and including cultural values of that of your clients. And I guess I'll just end with a very quick story about that I think I really learned a lot from, and that was in relation to palliative care. My mom, who passed away 20 years ago, she'd been ill for 2 years, and we'd gone through a number of physicians and home care providers and social workers, and she had cancer. So it was that trajectory that many of you are familiar with. And in her last days, we wanted to keep her home. We couldn't. We ended up taking her to a hospital, a palliative care unit. And the physician said to me, "When you've got your mom settled, come and talk to me." And so we got mom settled, and my brother and I went to meet with a physician. And we started on this list of symptoms and, the programs and what happened where and what diagnosis and what. And he stopped me. He said, no, tell me about your mom. What did she like to do? where did she like to visit? Who were her friends? And I learned more in that 5 minutes about what it means to be in a helping relationship. And I come back to it time and time again because it was just such an incredible feeling of certainty that my mom was in exactly the right place. And she died 11 days later, but it was a really amazing experience, and that has led me to my interest in palliative care today, really wanting to understand how we as the individuals work with people at the end of their lives.
Excellent. Thank you, Gail. We did have some comments come in from people online to direct where some of the resources might be available. The Personal Care Home Service Review is available on the Department of Health and Community Services website. And another participant noted that in relation to capacity and the Adult Protection Act, recommend looking at the APA formal capacity process, September 1st, 2015 document from the department, as well as videos they have developed regarding capacity assessment process. So that's some additional resources for you online that you can certainly check out. So I want to conclude the webinar for today and really take an opportunity to thank Gail for this stellar presentation. It was absolutely phenomenal, and for sharing her knowledge and experience with us today. Ethics is at the core of our profession, and every time we're able to come together to explore ethical issues in social work practice, it provides us with an opportunity to deepen our reflection and our thinking. Through knowledge exchange, reflection, and continued learning, we enhance our competency and strengthen our practices, which ultimately positively impacts on our social work relationships. So thank you again, Gail, for being with us today. It is truly appreciated. And thank you all for attending today as well. Again, the recording of this presentation, the slides, will be uploaded to the NLASW website for your future reference. And the practice documents that we did speak about during the presentation, so the social work and decision-specific capacity assessment resource, the ethical decision-making tool, and the guideline document for social workers in terms of medical assistance in dying are available on the NLASW website, so I do encourage you to check out those resources. For those who have attended 75 minutes or more today, confirmation of attendance is available now by clicking the yellow icon at the bottom right of your window. So I do thank everyone for joining today, and especially again to Gail for being our presenter, and webinar, using the webinar technology is a great way to reach as many people as we can from across the province, and share with your colleagues, because if they weren't signed up for the session today, it will be available on our website for others to view as well. So again, thank you so much, and enjoy the rest of your day.